Jessica, hi, and thank you so much for joining me at Faces of Digital Health for a discussion about AI, the ethics of AI, bias in AI, and everything that we usually don't talk about when it comes to AI. You also spoke about this topic at HIMSS Europe, and you actually started your presentation with what AI is not. So let's start there. Where do you see that people get wrong around what AI is? And I'm also very curious to hear what you're optimistic about when it comes to AI, since you have a very critical perspective of the whole field.
Yeah, sure. So first of all, thank you so much for having me, and thanks for having me at HIMSS Europe. It was a great time. In terms of what I think people get wrong about AI, so the three things I said that AI is not is new, magic, or intelligent. And what do I mean by that? I mean, first of all, AI has been around for a really, really, really long time, including in health. So, the very first time people started talking about the ability to use statistical learning as a mechanism of diagnostics instead of a clinician was back in 1959. So the idea is old. It's been around for a while. We've also been using AI in healthcare since around the early 1980s. That's a very basic form of AI and probably falls outside the definition of what most people consider AI to be today, but that is what it was doing. I was saying it's not magic because it gets things wrong very, very often. And I think people have bought into the mythology of it, especially since we've had the sort of arrival of generative AI and people using ChatGPT or Claude or anything in their everyday to-day lives. And don't get me wrong, I love those things. They're great for when you know how to use them. But they're so good at appearing natural that I think people forget that actually under the hood, it's just statistical prediction, right? It's just what is the statistically most likely next word in this sentence, and that can go wrong. So it's really not magic. I gave a couple of silly examples in the talk of HIMSS, but I'm sure everybody has ever done it. I think my most favorite one of all time was somebody Googling, how do I get the toppings to stay on my pizza? And the AI had come back saying, use super glue. So that's a kind of simple example. And then the third one I was saying really was this point about intelligence. I think the word intelligence is a bit of a misnomer in the way that we use AI. It's very clever branding, but if we think about intelligence when we're talking about it in a human context, we mean cognitive ability to understand sort of higher level concepts. And that normally means that you want to have a semantic understanding, which essentially means you don't just know the definition of a word and where it might fall into a sentence. You understand the sort of deeper meaning of it. And that really, really matters in health, because when you might say, oh, I'm in pain, right? That isn't just a quantitative concept. It has a meaning for that person's life. And an AI, no matter how fancy or how good we think that they are mimicking empathy or anything like that, it doesn't understand what pain is, and it doesn't understand anything else. So that's why it's not intelligent. So the sort of flip side of what I was just saying, then what we should think of AI being is this concept that's from Luciano Floridi, that it's agency without intelligence. So it is something that has a capability to complete a task in a way that if we were doing it as a human, it would be intelligent, but it doesn't need to be intelligent in order to complete that task.
Yeah.
So that's the difference. In terms of what I am excited about, am I overly critical? So the first line I always tell you to use when people say this to me is, I say I am skeptically optimistic. So basically, I think there is huge potential, but we need to be a little bit less, oh wow, isn't this amazing, and a little bit more, well, it could be, but what could also go wrong? But if we're not thinking about the what could go wrong and where do I put my skeptical optimism, I really think AI is an amazing tool for science. I think it can help us move our understanding of what causes disease on a grand scale? What are the best ways of designing a health system in order to make sure that we are keeping people healthy in the best possible way? What are new drugs that we haven't tried? How do we target specific types of tumor? I think AI is an amazing tool for that type of thing. I also think it's a fantastic tool for dealing with the things that humans are pretty bad at. So, if you think about healthcare systems, most of them in Europe are public healthcare systems, like you have in the NHS, or they're hybrid ones. We're pretty terrible at doing things like performance management of contracts, or looking at where you need staff, or looking at how you manage the operational flow of healthcare, because it's outside of our remit to be able to take into account so many different data points. So that's where I really think AI is going to make a huge difference if we get it right, is in science and advancing our knowledge, and in sort of back end operational efficiency. I don't think it's going to be a revolution in terms of diagnostics and patient care. I think it will make a improvement, but I don't think it's going to be revolutionary, transformative in the way that people think it might be.
Mm-hmm. So you disagree with those that predict that AI will achieve general intelligence by in the next few years. I think Ray Kurzweil says that that's going to happen by 2030. There's also been, some reports when at least one person at Google already thought that they're basically talking to the general intelligence. So what are your thoughts around that?
I think it's science fiction. And I love that people get hyped and excited about it, but it should stay in the world of science fiction. And people might say, "Oh, you're just being negative," but we can demonstrate this, right? I think the first prediction of when we would no longer need radiologists, we don't need radiologists, and AI is going to be able to do it. The first prediction of that was 2016. Well, we won't need them by 2016. Well, we are 10 years on from that, and we have a global shortage of radiologists, and AI is not fulfilling that job. And this idea that you're going to come up with something that is going to somehow surpass human intelligence is grossly unrealistic, because we don't know enough about human intelligence in order to build something that is capable of doing that. And also because of that point I made right back in the beginning of our conversation about semantic understanding. To have true general artificial intelligence, you would have to have something that is capable of being meaningfully intelligent rather than accurately statistical. And
Yeah.
I don't think we'll get that. Yes, we will have the arrival of AGI in the sense of like agentic AI, and being able to link together multiple different systems that do lots of different tasks, rather than us doing what we do right now, where we need to use ChatGPT 4.0 to make an image, and 4.5 in order to do some research. We'll be able to use a system that operates as an interface that links those things together, which gets us closer to the idea, but it's not genuinely AGI.
Yeah, yeah. One of the points that you made in the panel discussion around AI transparency was also around bias, and how bias is always going to be there. But we do need to create mechanisms where we can have warning labels the same way as we have on drugs, for which population a specific algorithm is appropriate. So are you already seeing any of that? The Coalition for Health AI in the US wanted to have assurance labs with uh, basically food labels that would tell you what was the data trained on, and where does the data come from. It seems that that idea for the assurance lab is currently on hold, if not that completely, because things turned out to be a bit more complex than not. So given your broad research of AI in healthcare globally, how do you see that governments or countries are trying to figure out how to really make sense of AI and regulate it?
That's a great question. So my point around bias that I made on the panel, I repeat it here, like you said, is really just that you can't avoid it. For one thing, the world is biased, and so the idea that you're going to build something inside the world that is bias free is unrealistic. And also, as I said, sometimes in medicine we do want bias. Sometimes there is this idea of positive bias because we need to know whether or not we need to weight in a certain direction if this is a person who has female organs or male organs or different types of ethnicities, etc. So we do want those concepts in there. Otherwise, we would be devaluing this concept of patient-centered care. In terms of then how you make things like labeling, we've also seen licensing come up as an idea a lot of times, which I think is also a pretty good idea of this. Oh, I license my product to be used in these types of circumstances, but not in these types of circumstances. But you're absolutely right in that I don't think you'll get widespread adoption of any of those concepts unless it comes from a regulatory perspective, because at the moment there isn't enough market demand to make it a pull instead of something that has to be pushed. We might get that later down the line in the same way that you saw that with sort of clothes production and the sort of anti-swoosh movement in the 90s, that all came from consumer demand more than it came from regulation. But at the moment, we're in this space where we need regulation. So what are different governments trying to do about it? And how are they thinking about it? Well, you've really got a sort of almost like a sort of three-way race happening at the moment between Europe, the UK, and the US. Let's just talk about them for a minute, and then we can talk about further afield. Obviously, you've got Europe, which is going very far down the strict regulation space. In health, you've got the interaction between both the EU AI Act and their MDR, the medical device regulations. And the EU AI Act is saying anything that is classed as high risk in the MDI is therefore in the MDR is classed as high risk in the AI Act, and then you have to meet these multiple levels of regulation, which includes ethical considerations, but there are also things to do with safety, etc., and transparency. And the pushback against that is from companies, especially SMEs, that it's very, very restrictive if you have to meet all of these different overlapping, sometimes duplicative, and I think in some instances probably even contradictory types of requirements. And the risk is also that within that you sort of create a Swiss cheese model. So people are able to, because the regs are so specific, it's a bit easy to think, oh, I'm going to jump into this loophole because I'm going to class myself as this instead of this, which means I'm able to go down this lesser pathway and that other way. On the other extreme, you've got over here in the US, where the new administration, so the Trump administration, is very, very anti-regulation of AI. It wants to really push this narrative of innovation striving against regulation and regulation being an unhelpful thing that gets in the way. And so you had the removal of the Executive AI Act, and there's massive pause on the FDA. So the FDA are the people who are responsible for regulating medical device, including software as a medical device. They've had a huge amount of their staff reduced, and also their roadmap for the development of software as AI is largely on pause. And instead, you have this really burgeoning market that is very confused, because you've got, at the one hand, the FDA saying, we've approved 900 and something medical software as a medical device. Most of those are approved as predicates. So it's this idea that there was something, they have evidence already that they work because there is a pre-existing device. That pre-existing device might be completely analog, and they're claiming that it's a predicate of an algorithmic system, which is not true. So that's a problem in and of itself. But then on top of that, 900 is a big number, but it's tiny compared to the number of things that are on the market. And so what we thought was going to happen was that individual states were going to try and enforce stricter regulation We saw that with California, for example. They had an AI bill that got blocked, but it was assuming that it was going to transition and get pushed through in a slightly different way. And we thought, oh, the states are going to take greater responsibility. Well, now what the White House is trying to do is a version of preemption. So it's basically trying to block the ability of states to develop their own legislation on AI for the next 10 years. It's got to go through the Senate before that becomes regulation, but it is a bill, and it is currently going ahead. And then you've got the UK, my hometown, who are sort of trying to be a compromise in between those two things. They used to be, before they left the EU, much more closely aligned with the EU, and even in the immediate wake of Brexit, were much more closely aligned with the EU. You know, we're very, very heavily pushing the narrative of AI ethics and AI safety, and that was how the UK was positioning itself as being a competitor, was basically by trying to say, we will become the place that is the safest and the most ethical place for you to develop AI in the world. Since over probably the last 2 or 3 years, including the change from the Conservative to the Labour government, we've seen them transition away from that and transition more towards the line of thinking of the US. So we had a big publication called Innovation Friendly Regulation. And my line really is that you should, first of all, have regulation friendly innovation. And the other thing that they put in that document was that we are on the side of the innovators. So I was like, well, surely if you're the government, you should be on the side of the citizen, not necessarily on the side of the innovator. But they're in this quasi space where they're really pushing forward on medical device regs, but holding back quite considerably on AI regulation. So that gives you sort of three different positions between this idea that, you know, it's a zero-sum game. So either regulation can win or innovation can win, or it's a win-win. I want to try and push forward this idea that you can have a win-win game, that you can have really good regulation and really good innovation. And actually, that is a topic that was starting to come up quite a lot in HIMSS, I think, was regulators and innovators are friends. Right? They should be friends. They shouldn't be seen as being oppositional, because if we come back to that point that we started this topic about talking about bias, me as a product developer, I don't really want something to go onto the market and then to get really badly negative press because it transpires that it's causing harm and there's bias in the product, but I was never told that I was supposed to tell people about that. And so it's actually more helpful for innovators to know the parameters within which they are operating. And that's really where we should be going. But at the moment, in this sort of triad between the EU, the UK, and the US, we're not really seeing that. And the parallels between those three different positions are largely mimicked around the world. China is kind of similar in that it's in a quasi space. You've got places like Brazil that are trying to leapfrog and do horizontal AI regulation, but they don't have medical device regulation. So we just see these different patterns. But that's the gist.
Yeah. Regardless of regulation or lack of it, AI is here. It's being used, whether or not it's with regular medical devices or if it's just with the tools that are consumer focused. And in that sense, you made several interesting points about how is that impacting medicine and how medicine is practiced. For example, going from basically treating patients to treating their data, and just going through the situation where, because of the data and because of the algorithms, we're actually not doing personalized medicine but targeted advertising, where you're basically clustering people based on their characteristic and then try to treat them based on that. My question there is that bad? What do you see as the implications of this shift? It sounds bad. I'm wondering, is it?
Is it bad? Is it okay? That's a good question. So first of all, I think with any technology and any technological shift, nothing is either purely good or purely bad. It is something that is transitioning. What I think is bad is when we start down this path, which I think is what we're on at the moment with AI, where these transitions are happening in a way without us thinking about them, right? So there seems to just be this huge enthusiasm that we want to adopt AI, and that's all we want to achieve is the adoption of AI. No one in the policy space or even in really like the healthcare leader space is saying this is the end goal. This is what we actually want to achieve with the use of AI. And so as a consequence, I think we are seeing this shift, as I said, this way from this idea of sort of patient-centered care towards this idea that's much more akin to targeted advertising in a vacuum of thought. And I think that's bad. The reason why I think that's bad is because, first of all, in a space that we never wanted to end in. And it also means that there isn't really a chance to think about the implications of that, and therefore how would we design that transition to make sure that what we do end up with is something that people want. And so let's unpick that a little bit in terms of why it sounds bad and why it currently is bad if you make this transition right now. The reason is because if you are treating a whole person, come back to that point I made about intelligence, there you can see them. So people don't really tend to express themselves when they are talking about health and problems they are having with their health in ways that are really precise and really quantifiable. You're much more likely to go to a doctor and say, I don't really feel like myself, or my mood is off, or I've been very tired lately, or I feel like my clothes don't fit right because my stomach is swollen. These are all sort of more qualitative indicators, or you might say, I just don't feel like very satisfied. I don't feel as though I'm able to fully participate in my life. And a doctor, obviously, there are bad doctors who don't do things perfectly, but we'll just, for the minute, we're talking about an idealized world. We'll be able to have a conversation with you and talk about, okay, well, why is that? Have you been stressed at work? Have you been going through a divorce? Have you started eating something different? Have you started a new exercise regime? Oh, you're taking this medication for cancer. And yes, maybe it's killing your cancer, but maybe it's also really devaluing the quality of your life. And maybe we should be treating you with a different type of drug. You can have all of these semantic conversations that are really surrounded around the patient. As soon as we move into that data space, we have to assume that there is a one-to-one relationship between the patient and their data. And we know that that's not true. Most data shadows or data twins, or whatever phrase you want to use, are not an exact replica of the person. They miss out all of that qualitative concept, for one thing. So they are not thinking about quality of life or meaningful interactions. So that's the first thing. They don't record things that are non-quantifiable. The second thing is that we know that we don't have great data on everyone. So it's much more likely that my data self of my health is closer to reality than it is for somebody who has lower access to digital technologies, has lower levels of digital health literacy, or has a lower level of trust in the healthcare system. And those people are, the data that we're treating is very thin. And so trying to put them in a bracket based on, or a bucket, on very, very thin representation data that might be incorrect is probably quite dangerous. The example I've given to sometimes make this a bit more concrete is if you ever go into your Google profile and see who Google thinks you are based on your searches, you can see whether or not it is categorized you correctly based on the inferences of the data that it has about you. And so I used to have a Google profile that was my personal Google profile and a work Google profile. I don't have that anymore, but I used to. And when I did this, my personal Google profile was pretty accurate. It was like, okay, we get that you're a young female, you're obsessed with things that are sparkly and Taylor Swift, and you still want to watch Hannah Montana, right? They got it quite right. My work Google profile, because I was primarily looking at things to do with tech and statistics, etc., thought that I was a man in my 20s. It was wildly wrong because the data it had collected and the inferences it had collected on me were inaccurate. Now imagine that we're doing that with health, and you never see the person in order to test whether or not the data thing is correct versus the patient. And you start seeing the way in which we start to go wrong. Now,
Yeah.
if we acknowledge that that's what is happening, and we say, right, yes, this is what is happening, this is what we intended to happen, you can put in place regulations or design patterns and thought processes that mean those risks are reduced. But because we are not having those sensible conversations right now, the risks are mounting instead of reducing. And that's what's bad.
Yeah, absolutely. I remember an example from quite a few years ago, even before generative AI was widely spread in the market, when the first risk scoring software solutions came to the market, and there was this huge article in Wired where a woman couldn't get her pain medications for severe pain because if you get a prescription for pain for your pet, for your dog, it also goes to your name. So basically the software detected how much drugs she took from the pharmacy, and when she came to seek medical care, the doctors were alerted that she's potentially doctor shopping, or what's the expression where those addicted to pain medications go from doctor to doctor or from ER to ER to just get more medications that is good for them. So those kinds of examples are definitely scary, and there's plenty of more that we could mention.
Yeah, exactly. Perfect example.
So one thing that kind of then this discussion leads to is to the question, with AI, we want to make care better, more effective, more predictive, personalized, but could it be that we're actually making care worse? What does the research say so far?
So I think we are making care worse. We did a systematic review about 6 or 7 months ago of tools that were doing risk stratification for demand. So these are things that are used in the UK already at scale, and they're algorithms that come from really good places like Johns Hopkins in the States. These are not things that are just built by a teenage coder in their garage. They're verified systems that are designed to predict whether or not certain types of patients are going to need more or less care, specifically whether they are going to need an emergency admission or not. And the idea is that you can then go in and intervene earlier, right? So we think this patients or these types of patients are most at risk of having what's called in health an avoidable admission. So somebody who's going to end up in hospital, but we could have got there earlier and make them not need to go into hospital. And so whether that be somebody who's an elderly person, for example, who might be at risk of falling, okay, let's go in and make sure that they have stability aids. Let's make sure that they are not getting dehydrated, like all of these types of things. And what that systematic review showed was almost unilaterally, care is made worse for people who are non-targeted by these algorithms. So if you're in a bucket that the algorithm doesn't have a lot of access to data on, or it's making incorrect or biased inferences about you, your care is going to become worse. You're going to either end up being overdiagnosed or grossly underdiagnosed. And also at a systemic level, the expense drop that was expected. So we are expecting that these things make care more efficient and therefore more cost effective. It was not happening. But actually, when we run these types of risk stratification tools, and this is a very simple example, there are others that do more complex types of risk prediction and risk strat, drives people towards health care centres rather than away from it. And one of the reasons being is that all of the things that we've talked about already around the idea that data is wrong, etc. But the other one is that your health is not necessarily something that you are entirely in control of yourself. So most of this personalized predictive idea concepts that come up is this idea that I, Jessica, or my brother Jamie, or my other brother Elliot, are entirely in control of our health outcomes. And all we need to do in order to make sure that we never become unwell is be given really personalized advice on our risks that say, hey, Jess, the life of the mind is not great for the life of the body. Right? You want to sit in a house and read all day, but sometimes it would be really good if you went outside and you ate healthy food and you sometimes went for a run, or maybe you should go and speak to somebody about why you're so anxious all the time. That is assuming that I can do that, which means that I have access to those systems that are going to enable me to do that. That means that I live in an area that is walkable. It means that I live in an area where I can get access to healthy food, that I can afford to buy healthy food, that I am not working 3 different jobs and then I have a child at home and I also need to be able to look after their child, and maybe I don't have any time to get out and go for a run. So all of those things that we call the social determinants of health are actually far more impactful than things that we can make in terms of individual behavior change. But the way in which we are over-focusing on the use of AI for predictive, individualized mechanisms forgets that. And so what we are really doing, I think, is creating a system that is going to lead to massive levels of victim blaming. We are going to be saying, hey, we told you what you were at risk of developing. You didn't do what we told you to do. You've now become unwell, and that's your fault. So we don't have responsibility for dealing with that. So to come back to my point that I made at the beginning when you asked me about what I'm excited about, I think we can avoid that happening if we use AI as a mechanism for science and for understanding system level complexity of what drives improvements or disimprovements in health. And that might mean that actually we don't necessarily want to focus on hyper-targeted individual care. What we actually want to focus on is urban design or policy with regard to food pricing. And that's what's going to make a bigger difference to our population health. That is what's going to really improve efficiencies in care, because people are not going to become unwell and they're not going to need the healthcare system as much. And that's when we're going to get all of the benefits. And that's without even touching on the topics that we've already spoken about the fact that people have different levels of data about themselves. I use the examples of myself and my brothers. We probably get pretty good quality recommendations from an algorithm. Somebody who is in a completely different scenario, whether we're talking about people of color or we're talking about people who don't have such good access, or we're talking about people who live in a different postcode or whatever it is, intersectionality arises a lot. Their recommendations are probably going to be wildly off, or they're going to be ignored completely because they don't exist in the data space. And that's where I think we are really at risk of making care worse.
Yeah. I could give another example of just all the wellness devices that track your sleep, that track your weight and the structure of your body. But even if you use a plethora of those apps and have a lot of data all around heart rate variability, sleep, etc., because those apps don't have information about your chronic conditions, and because at the moment there's still no way of inputting in Apple Health or other tools what conditions you have, those tools then give you inaccurate recommendations or don't recognize that you are feeling bad when they, basically based on the data they collect, think you're doing well. So
Exactly.
yeah. So we mentioned earlier that when it comes to algorithms, bias exists. We should know who the algorithms work for and who they don't work for, which is a different debate from the usual discussion around algorithms are inaccurate for the whole population because they don't cover all the races, all the genders. So on the one hand, what we're saying is we shouldn't exclude algorithms from their use just because they serve a specific population. But what I'm wondering here is that going to become an excuse to just diversify the data, to support policies that try to gather more data about women, about people of color? Did you notice anything in that sense in the research that you did?
Yeah, so I think that's a really good point. And actually, that's one of the reasons why I think it's important to make this point that bias is probably a little bit unavoidable. Because I do think otherwise there is this drive to see it purely as being a statistical problem, right? So it's purely because we don't have the perfect representation of the population. My old boss Ben Goldacre, he used to refer to this idea as God's giant SQL database in the sky. So this idea that we have a perfect one-to-one match of the population, and once we have reached that level, we'll never have bias anymore. And exactly as you have just alluded to, when you have that kind of narrative, the policy that it suggests we should do starts leading very much down the road of surveillance, and this idea of increasing recording. So all we need to do is record more people and record more data. That forgets that bias in an algorithm ultimately results from social issue, right? So if we take the example in the UK, there is something along the lines of 26% of medical records do not have ethnicity recorded in their record. There are two primary reasons for that. The first one is that ethnicity is not a static variable. It changes over time depending on how people identify. And secondly, there are really good historical reasons as to why some people don't want their ethnicity recorded in their record. We could probably start making a case, for example, in the US right now. I really highly doubt it. People want it in their record whether or not they're trans, because the implications of who might get access to that data is too high. And so we don't want to use this idea that because algorithms might be biased, etc., what we want to do is increase surveillance and create this perfect mechanism of data. Yeah, we want to start making policies about making sure that data is collected more accurately at source and more fully, but that doesn't mean we need to start recording everything about everybody all the time. Instead, what it means is that we need to be aware of the limitations of the data space and when we're moving towards an algorithm. And we might want to use the fact that bias exists in data as a diagnostic of the fact that there are social problems there to begin with. The topic of my friend Marta Ziosi's PhD thesis was essentially this. We can use the fact that bias exists as a way of saying, well, why? Maybe that's not just because we need to collect more data. Maybe it is because there are issues to do with trust, or it is to do with issues to do with access. And so use it that way, right? Okay, I'm going to go and fix the social cause of the bias, and I am at the same time going to make sure that when I recognize that that bias exists, I have mechanisms in place to ensure that it doesn't cause harm, and I'm not going to misdiagnose people because I'm using an algorithm that's never seen a person that looks like that before.
I believe we gave a lot of food for thought to the audience listening to this episode. Before we conclude, what research are you currently focusing on? What's the next thing that you want to get answers to?
So, well, that's always a dangerous question. I always want to know the answers to everything. And when sometimes people ask me what is your ideal superpower? My ideal superpower would be to not need sleep, because I think it's a waste of time. But that having been said, I'm currently working on them, but I was talking about that transition from individual health to population health. So I am trying to make a case for understanding why we are designing the function of AI in the global health system as optimize individual health instead of maximize the population's capability to be healthy. And so I want to understand why that's happened, what the consequences of that are, how we can flip the narrative, and how we might achieve that in practice. That's my current main focus.
A very important one for the sustainability of healthcare systems around the world. Jessica, thank you so much for joining me today and for sharing all these insights. I'll definitely get back to you again for some follow-up questions in the future.
Thank you so much for having me.